Hi, this is Chandan Patel with Fits on the Go video blog. I'm here with Dr. Bangalore from NYU, who just presented on a bit of a controversial topic in regarding discontinuing beta blocker therapy post-MI, something that we probably don't do enough of. Thank you for taking the time with us. So if you don't mind, just a little summary about some of the things that you discussed today in terms of what we should be doing with our beta blockers post-MI.
Yeah, definitely. So I think the key thing to understand is, we have a wealth of data, and we have to be cognizant of the fact that things have changed. And as long as all of us agree to the fact that the way we treat patients with an MI is different than what we used to do 10 or 20 years ago, we know that we have to be very careful in applying the results of those trials to what we do today. In terms of the practical aspects of it, what I would say is, if a patient has a large MI, and we know that there are some patients who present late, the door-to-balloon times are longer, but if these patients end up with a low EF, they should be on a beta blocker, and plenty of clinical trials showing that. And if these patients come back to you and say, you know what, I'm feeling a bit tired, etc., etc., I'll still push these patients to be on a beta blocker because we know that in that setting, the ejection fraction can improve, the exercise tolerance can get better, and in fact, many randomized trials will say that it is life-saving for those patients. Now, if on the other hand, we have had patients where our door-to-balloon time is 15 minutes, total ischemic time of under 60 minutes, and these patients come out with a normal EF. In these patients, I tend to keep them on maybe for up to a year. But if they have any kind of adverse effect, if they're feeling tired, impotence, etc., I have a lower threshold to take them off beta blockade. So I think the bottom line I want to say is, we should stop using cookbook medicine for all patients, saying that you need to do all X, Y, and Z, and individualize patient based on the risks.
Do you find that there's any particular beta blocker that you might keep people on?
Yeah, absolutely. So we know from plenty of studies that the newer vasodilating beta blockers, either it's carvedilol, nebivolol, etc., have not only reduced side effects, reduced propensity to cause new onset diabetes, reduced propensity to cause dyslipidemia. So if I'm choosing a beta blocker, that will be those beta blockers that I would choose.
For those that suffer post-MI with reduced ejection fraction, you do keep them on beta blocker therapy, and they happen to improve their EF. Do you maintain them then lifelong, or would you say that after you've improved after a certain amount of time, then it's time to come off?
Yeah, so that's a great question. So it really is evidence-free zone because we really don't know if they're improving because of beta blockade, or is it because when you have an MI, your myocardium is stunned, and at 1 month maybe your EF is improving because you're out of the acute phase of myocardial infarction. But if for whatever reason I believe that the improvement in EF is because of beta blockade, I tend to continue them on.
And last question, how do you feel we do generally, either whether it be cardiologists or even general practitioners, in terms of effectively beta blockading patients? A lot of the times we get patients that might be following up from a primary care provider where they're on a standard beta blocker dose, but not very effectively beta blocked.
Yeah. Absolutely, and this has been shown in multiple studies, and this is one of the reasons we emphasize a good dosage of beta blocker before the time of discharge, because multiple studies have shown that if you start a patient on say 3.125 of carvedilol at the time of discharge after their MI, that's the dose they'll stay on for up to a year. So there is this clinical inertia, either it's different providers, etc. So I think it's critically important to make sure that you discharge them on a stable, good dose of beta blockade, and make sure that the follow-up providers actually have a clear instruction as to what to do. If a patient's EF is low, they should be titrating to doses which we are seeing in clinical trials. Because if you don't do that, if you just have some beta blockade on, but of course, there might be good reasons why you don't want to titrate in some patients. The side effects is a good example. But if there are no side effects, you should really be going to doses which has been tested in clinical trials.
And you would advocate for aggressive titration as an inpatient, or just close follow-up and titrate upwards as an outpatient?
Titrate upwards as an outpatient, especially within the first 6 weeks. Gone are the days when we used to say titrate slowly. I mean, this applies to everything, even for hypertension. If a patient's blood pressure is out of control, we rather get them within the zone in 4 to 6 weeks rather than doing it over 6 months period of time. Again, but at the end of it, everything is risk benefit. I mean, if you have a 90-year-old frail patient, you go slow. So I think the bottom line for all of this is, we should stop using cookbook medicine for everything. I mean, you can have a baseline, what you need to do, but then individualize based on the patient in front of you.
Thank you so much for your time.
Thank you.
For more videos like this, please visit youtube.com/video fits on the go. Thank you.